Abdullah Radian. Oh, sorry. Dr. Abdurrahman Radian. Which, oh. Dr. Ali Jeli from King Fahad Armed Force Hospital, Jeddah. Dr. Dafer Al-Sahnani from King Abdulaziz Cardiac Center, Riyadh. And Dr. Mansur Badr Al-Mutairi from Prince Muhammad Cardiac Center, Medina. And also Brother Muhammad Al-Nazif as a pediatric cardiac sonographer. Oh, he's sick. Sorry. And our sister Fatima Al-Gharibi as cardiac head nurse. And we have also Dr. Muhammad Abdullahi Musa from Sudan. It's from Sudan, yeah? And also some guests, it's not mentioned here, so no problem, yeah. As we know, congenital heart disease is the most common congenital anomaly and remain one of the leading causes of mortality. With a prevalence of 9 per 1,000 live births, it is estimated that in Indonesia, approximately 45,000 new congenital heart disease babies born each year, with half of these cases consisting of VSD, ASD, and PDA. Up till today, total of 34 patients have successfully undergone transcatheter closure for PDA, ASD, and VSD, with several more scheduled for today and Monday and Tuesday. So come to a total almost 60 patients will be done. This jury represent a spectacular humanitarian aid effort generously provided for our patients who come from various regions across our country. Today we will listen to two experts who will share their valuable experience. And then first, I would like to invite Dr. Mansur Al-Mutairi, who is going to talk about 3 topics. He's a strong guy, so for 45 minutes with 3 topics is okay for you. Yeah. The first topic is challenging cases in a charity mission, which you have done. I heard that you have done hundreds of charity missions in Morocco, Sudan, Tanzania, and many other countries. You are very generous. And then the second topic is about partial anomalous pulmonary vein drainage intervention in care lab. And then the third topic is about sinus venosus defect transcat closure with self-made cover stand, which is a new. These 2 topics is a new topic for us in Indonesia. We have some fellows here, and then this session is relayed by all of pediatric cardiologists in Indonesia. So they follow your topics, and I would like to ask you to present now.
Assalamu alaikum. Good morning, everybody. It's my pleasure to be here in this beautiful country, beautiful morning. I'm glad to be with you here and to share these few topics or presentation with your guys. Thank you very much for the support. Thank you very much for the unlimited help in the catheter lab. We found it a very wonderful mission. Thank you. So, well, we choose the topic of challenging cases in the cardiac mission, which we are doing this mission since 2009. So for very long years we are doing this charity mission. I have no disclosure for this talk except I love charity work, and I'm delighted to be part of the King Salman Humanitarian Aid and Relief Center, which encourage the Saudi and non-Saudi citizen to do the charity work across the globe. And we are really delighted and thankfully for this center to support us. As you know, we used to call ourselves a mobile cardiac team across the globe. So we are a volunteer of health professional, and we are supported by many organizations. Initially was Muntada Aid, but currently since 2009 we are supported by King Salman Humanitarian Aid and Relief Center. We are very highly specialized group for the healthcare provider, and many teams, surgical and medical team, and these teams are quite large, highly specialized team. We've done the intervention, for the across the globe in many places, and in many countries we were the first people who do intervention in that country. So as you can notice here, the first PDA device we put in Tanzania, and this was the first PDA or ASD device in Tanzania, also the first device in Senegal, in Djibouti. And what I'm trying to say is we visit almost many countries. As far as I collect, more than 17 countries. Okay? We as a pediatric team, we are more than 60 volunteers from 8 cardiac centers in Saudi Arabia, and we have almost 14 nationalities. The team are totally volunteers and from their vacation. But for your knowledge, Saudi Arabia encourage and support people for charity work. And each one, whether Saudi or non-Saudi, working in Saudi Arabia, they are entitled for holidays. They call it volunteer holiday, which is from 2 to 4 weeks, so almost like a month. Each year, it's a volunteer vacation paid if you want to do intervention, which is a very good support for a volunteer work. The story of intervention or volunteer work, we started quite a few early, 2009, as a 2 team only. We started, this is mine, this is mine, and this is Dr. Jamil Ata. For me, he's the founder of the charity work. We started as a 2 team. This was in 2009. We were in Yemen. So, and then the team get bigger and bigger and bigger. And currently, each time we go in mission for almost a week. And the member between 5 and 30, it depends whether it's a catheter intervention or catheter and surgical treatment. So we spend like 7 to 10 days, and in each time we do about from 60 to 100 patients each mission. And if you notice, this is one of the largest specialized charity organization of this scale. Okay, Before 2019, we were supported by other like Muntada Aid and Islamic Relief Organization in Saudi Arabia. And at that time, before 2019, we've done the campaign 26 times in 2 continents, and we're doing almost like 280 cases per year. So this is considered like a moderate cardiac center. Then afterward, supported by the King Salman, we've done in the last 7 years more than 104 missions. But by the way, this is adult and pediatric. And we've done almost like 1,127 per year mission. So actually, it's a quite big number of pediatric and adult cardiac intervention, whether surgery or catheter. I mean, we are featured in many breast news journals, TV channels, and we are welcomed and visited in each country by the high authority people there. For example, this is the president of Sudan at that year, and this is the president of Tanzania, and this is the ambassador, British ambassador in Morocco. So in each country we visit, we like the, what we say, we always received by the honesty and generosity of the countries, as we did and receive in this country. Thank you very much for your host and your welcoming, cheerful talks. So let us go for the challenges and interesting cases. The charity work is always challenging. Why? Because the source of the challenges come from different places, which is the catheter lab, the equipment, the surgeon, the ICU. So what I mean is the environment. This is, you notice here, Dr. Ali Jelly. We came quite early in the morning before the hospital opens, and it was under the shade of this tree. This was in Mauritania, in Nouakchott. Okay, when you go to the cath lab, we do our arrangement in the catheter lab like this, and we spend time before the team come to fix our items. The other is the pathology itself. The pathology itself, as all of you know, patients are different from place to place, from area to area, from race to race. So we face a lot of difficulties. So BDAs, in my belief, are different from place to place and difficult to treat sometimes. In this place, what we found, huge BDA, and people are closing it, which is wonderful, and we learn from your guys, by the way. Yeah. The other problem is the intervention itself. You know, when you have multiple group, whether the charity people or the local people, each one has his own skills, each one has his own approach to the problem. And we face challenges, we learn from each other. So the source of problem and challenges came from many, many places. Okay. This is just to take you through quick, challenging, interesting cases. This is a patient with 3 days old, critically ill, on ventilator, acidotic, inotropic support, oliguric, and the echo showed severely obstructed TABVD. Okay, he was very, very, very sick. He was in almost, he required a high frequency ventilation, and at that time we were called to help him. So we took him to the catheter lab. We tried to shift the physiology from obstructed TABVD to a non-obstructive TABVD. As you can see here, these are pulmonary veins draining to a confluence, vertical vein obstructed and joining the SVC. So what we've done, you see, when we cross there and inject, we found this channel, you see, joining the innominate vein. Okay? So we planned to put a stent, but it was difficult to put a stent because severely obstructed, so we have to balloon dilate with the coronary balloon. See here. And we thought, well, it'd do the job. But unfortunately, when we tried to put a stent, the stent embolized. coronary stent, which is hard to embolize, but in difficult case it will. So we have to retrieve the coronary stent, and we have to put another one. This time, you see, we have to balloon initially, and then we have to put a coronary stent, and then the obstruction relieved, and then we inject from this connection just to show you it's non-obstructed anymore. This patient was discharged from hospital, and we managed to repair him in 6 months' time in the same country. So it was a catheter and then surgical, and he did very, very, very well. So we were very, very happy to help this patient. Why we think this is a good approach? Why? Because we believe this is a palliative procedure, okay? And we changed the pathophysiology from obstruction to no obstruction, and the patient had a semi-elective surgical repair later on. So this patient, theoretically, he need less ICU stay. We could have taken him to surgery, but it will take time, and it will obstruct the bed for us in the ICU. So we thought we do it in this way. This is another patient, 7-month, tetralogy fellow, severe RVOT and sub-RVOT obstruction with a small BDA, and we were doing a mission in, I think in Sudan, and this patient, while waiting in the screen room, he had a cardiac arrest. You see, if you notice here, the physician said he knew this patient, there is severe RVOT obstruction and there is a small BDA. So we have to rush and do emergency BDA stenting, and it did work very well, and this is the BAs after that. And he had a dramatic response with increase in oxygen saturation. Then what we noted as well, there is a the issue of severe subpulmonary valve stenosis is a major problem in Sudan. So we have to teach the people there how to do a stent in the RVOT stent. You see, this is the RVOT stenting. So the people there, which is my friend Dr. Sulafa, she learned how to do these procedures, and lately she's doing them, and she sent me this image by WhatsApp. She's doing the procedure now, and you see now she saved a lot of patients, and really the group is delighted to her work in Sudan. Okay, this is the patient before and after. It makes a big difference. This is before the procedure, you see the after procedure. Okay? This is another very, very interesting patient, which is, I will tell you, a challenge from the operator, which is myself. I'm not blaming anybody else. So what happened? We have a patient, a VSD, usual VSD, but it's a very posterior muscular VSD in a 6-year-old patient with significant shunt, you see here. So for us, it's just a standard case. So we took him to the catheter lab. You see the VSD? It's about 7 millimeter. We put the device, the angiogram, you see, clear muscular VSD. So what happened is we crossed, we have to make a loop, and then we did the occlusion, and we felt it's fine. You see, the echo is also okay, no more residual shunt. We were very, very happy. And then we checked, everything is okay. You see here, it's almost sandwiching the septum there. We were happy. We released the device. But for a reason or another, we realized something wrong. See, when we released the device is not normal. It's stretched too much. We realized there is a problem. But we have to figure out what happened. What happened is the device is between the tricuspid valve and the LV. You see, in a different way, see the device here? This is tricuspid and this is the LV. So we were in trouble in a catheter lab. So what happened is we have to fix this, our problem. So we bring, guiding catheter, try to push the this disc into the RV and we fail. So we have to use the bioptome to push it down. Unfortunately, it did not work. We did our best to embolize this, but did not work. So then what happened is we put a catheter wire. You see the wire here, here, here. Between the RA, I will call it now RA disc, and the tricuspid valve, we put a wire to the RVOT, to the PAs. And then we put a balloon there. You see, this is not working, this slide, I don't know. Can you play this one, please, for me? This one. Click it, this one. It's not working? Okay. No problem. It's okay. I don't know why. But anyway, well, I'm trying, so I push a balloon between the RA disc, and what happened is the disc embolized to the RV, and now the shape is normal, and this is the after procedure. I know you are worried about the tricuspid valve, but the tricuspid valve was fine. You see, what is the color? There is color, but I don't know, it's not showing. You see, this is the device afterward. This is the color, but I don't know why it's not playing. Anyhow, so this patient has successful repair. This is another very interesting patient. Wait. Why it's not working? This is a 10 years old with severely depressed function in Yemen, whom we saw, and then you see, if you see here, has very abnormal vascular disease. You see here, it's almost no flow to the innominate. He was born like this. It's a kind of arteritis, severely obstructed. This one is not, it's almost interrupted here. So we have to take him because the function was so down, depressed. He was admitted all the time in hospital. So we have to put a stent in 2018, and then we have to come again. Why it's not playing? Wait a minute. You see, we have to put another stent, just let it play for a while. Yeah. Okay. And then in 2019, just for a while, it will, yeah. You see, when we come later on, again, he has a problem here. This is another 1 year later. This was in Yemen again. So we have to take him again. You see the problem? So we have to take him again. We have to put another covered stent, you see here. Okay? And then, why it's not working? I'm sorry, but this is should work. Can you please click forward? It's not progressing. Anyway, to cut it short, this patient has successful stent of the segment that you saw with almost like and stenosis and aneurysm, and he did very, very well. And this patient, since that time, 2009, till now, is doing very well. We have to visit him, in the coming few years for another checkup, and I will update you with the picture. You see here, so we have to, you see, this is covered stent, Optimus stent, which is not available. And you see now the injection. You see, this is the injection. It looks very good. This is the after, at the end of the intervention. So this is another difficult
Dr.
patient.
Mansour, can I ask you a question? If you put the cover stand there, and how about the vertebrae artery? Is there a risk of the paraplegia? Because I have an experience also with the low ejection fraction heart failure with prolonged ventilation with the mid-aortic syndrome. So at that time, I put the cover stand, but it's too long. But alhamdulillah, the patient can, well, there's no paraplegia. What do you think about that?
Dr. Raditwan, you asked the right question. Why? Because we were debating this in at that time in the catheter lab with the surgeon. But we have to do something for this patient, and the surgeon refused to do anything for him. because this is a very complex for the surgery to go for intervention. But luckily enough, nothing happened in this patient, and he's doing very well. If you notice, most of his vessels, even in the neck and neck vessels, tortuous, obstructed vessel, but we cannot do more than this. But he did very well. But this was theoretically was in our mind. This is another patient. If you notice here as well, see how bad is this arch? Yes. Improved significantly. Yes. Yes. You see here, this is another patient with multiple aneurysm. This was in Egypt. You see? So we have to go for definitely covered stent. Okay? So we put the covered stent. But the problem is, when the people, the assistant push the CB stent, you know, the covered stent slipped down and unnoticed. So we stent this patient, and then what happened? We inject. You see here? You see something here from here? So there is a leak in that aneurysm, or maybe rupture. We don't know. So we have to rush him immediately for another covered stent, and it sealed the problem significantly and see the problem. You see no more problem. You see here. So this is before intervention, and this is after intervention. Okay. This is part of the problem we face in mission. The stent embolize or move forward when we push the balloon backward, and this is the stent inside the patient. So we learn one technique to put something, a forceps here, you see, and then push the balloon down. You see here, we push the balloon, you see here, inside the patient. So it will work very well most of the time. Instead of taking the sheath out and the stent again, no, we do mounting inside the sheath, just to save time. I thought I would show it to you. This is another patient, 30 years old, but the problem in this patient, we have shortage of wires. We use a soft wire, unfortunately, for this patient, and then we put a stent. It looks okay, but the wire is very soft. It's not stiff wire. What happened with the inflation? See, no, I'll go forward, sorry, backward. See the play, please. See the inflation here. See, okay. See the inflation here, and then the wire. It keep coming down. It's not in my hand. You see, it's almost. But I'm supporting with this catheter. But nevertheless, did not help. So what we've done, I have to snare the wire from the arm because I don't have wires. So we have to put another stent inside the previous one and fix the problem. So the challenges is always there. Sometimes technical issue, sometimes item issue. So we have to face the problem. This is another multiple pathology problem, fistulas. We have to engage them and include them. I'm sure you've done more than that. But this is very interesting, very different anatomy. And sometimes the challenges is there. But we learn how to overcome these problems. This is another, you see, the big coronary is fine, and we are including from the RA side. They're just different pathologies, just to show you this. This is an 8-year-old boy with a huge fistula between the left system and the. This is rupture sinus of valva. Okay, this patient, this is interesting because if you see here, we occlude the fistula here, but I want to eliminate the whole giant aneurysm. So we occlude here, and then at the end we occlude it here. So we contain the aneurysm, so no clot can move anywhere. I want to make it short. You see, we occlude it here, here, and then here. At the end, we put a device here, BDA device. Very interesting. This is a patient. We do AB window, and we do our surgeon do the AB window on bum. Off pump, just ligation. So what happened? There is residual BDA. Residual shunt between aorta and the pulmonary artery. So we have to bring again and to cross and put a device. Sorry, can you go back and play it again. Okay, this is a patient, 15 years old boy in Egypt who had a history of trauma. He is a boy who played karate, but suddenly he felt severe breathlessness and heart failure, and this is what they found: huge aneurysm and ruptured LV. Nobody knows why. So if you notice here, there is big aneurysm here, the LV ruptured, so we have to go there. Just to play, wait a minute, yeah. We have to go there, we have to rush in and put a device there and see the problem completely. So this is very, very, very unusual patient. I'm sure that senior people, they hardly see a case like this, but it can happen. The other problem is, which is common in adult, is post-MI VSD. We face in some countries, they ask us to do intervention, and we can do them with difficulties. But this is an Oculotech device used for post-MI VSD. I think I want to maybe end with this slide. This is a patient in Tanzania, an adult patient with large BDA. We have to put initially an Oculotech device, you see, and the problem is she had residual shunt. She was into hemolysis, and almost renal function was impaired. So we have to remove the device and put another VSD. So we have to remove the device, and then we put another muscular VSD, and it did work very well. Not sure what's wrong with the slides. Yeah, you see now the device is fine. This is a patient whom we met in Yemen, severely blue single ventricle, and the gland circulation was drained by the azygous vein, which is going down, you see. So we have to put a large 20 millimeter ASD device in order to protect the stealing from the PAs. And she did very well after the procedure. This was her sister was a doctor, and she said she's dying almost each day. But after the procedure, her life was saved. This is a patient with forward flow, which is probably not interesting anymore. This is a patient where AV malformation, and he was labeled for lobectomy. So we have to do lobectomy in the catheter lab by putting sorry. Can you play this one? Yeah. We have to put a large ASD device to occlude the whole segment of the lung. The saturation improved from 45 to 85 or so. So he had a significant improvement in saturation. Just to cut it short, that King Salman is non-profit charity organization group, and we are treating patients with congenital heart disease as well as adult, but our team is a congenital heart. The host country is the one dealing with the list, not us. We always let them choose the cases, and when they choose the list, we will come as a team and evaluate, and we can say we can do that or we cannot do it. So thank you very much for your attention.
Yes, you can continue with the second topic.
Okay, next slide, please. Partial anomalous. How many? Because yesterday they told me you have 2 hours, and you are telling me 45 minutes.
It's okay. It's okay. It's free
okay?
for you.
Okay. This is, which one is this? Okay. Okay. So this talk is about the catheter intervention for the management of partial anomalous pulmonary venous return. As you know, this is a rare congenital heart disease up 0.7%. And it's difficult to detect, often is underdiagnosed, and all result in a left to right shunt and volume overload. And for many, many years, we tend to say, leave alone, even if the signs of right volume overload. So, the right-sided pulmonary veins usually have connection to the SVC in a partial anomalous, or to the RA coronary sinus, or to the via scimitar vein, which is the majority. But the left-sided partial anomalous pulmonary vein generally connect to the innominate vein SVC and the right atrium in 3 to 8%. Frequently associated with other congenital anomalies like ASDs or scimitar syndrome, coarctation, or other anomalies. It's almost up to 15% of partial anomalous left pulmonary vein associated with an ASDs. It's a very anatomical subtypes, but we need to do an investigation like echo, CT, and 3D printing sometimes, in some cases, to detect the anomalous pulmonary veins. No definite classification has been proposed. There are some classification which is done by Al-Sufi group to classify the partial anomalous pulmonary vein. In my opinion, partial anomalous pulmonary venous connection has a dual drainage. Okay? And we've done cases, if you review literature, it's only few case reports that deal with the catheter intervention in the catheter lab. But majority of them has dual drainage. Okay? Let me now share with you our experience for such pathology, which is a 10-year-old boy who came. This is actually the nidus for thinking what to do with those patients. This is a patient with a 10-year-old girl. You can see here, the right lung is drained by a scimitar vein to the IFC-RI junction. So it was significant shunt, and the patient has no systemic collateral. She had a surgical repair, and the surgeon reroute the scimitar to the LA. And then what happened 1 month after surgery, the patient was doing very well. 6 months after that, the gradient at the baffle started to increase to 3 millimeter mercury. The right ventricle pressure remained normal. So you see here, so we have to take her to the catheter lab again. So this patient, after 6 months or a year, you see, when we inject, we found the pulmonary vein on the right side almost recruited or restored. So for me, this is a very interesting pathophysiology. That pulmonary vein, sometimes the drainage is dual, but it depends where is the largest, so it will take the most of the venous drainage. So in a different way, if we occlude that vein initially, we may have a go with this patient to recruit his vein. So this is after this, we try to evaluate each patient about dual drainage. So you see, this is before, and this is the before. This is the scimitar, and we report this one. She had complete obstruction of the scimitar vein after surgery, but the normal vein was restored normally, and the PA pressure is normal. This actually drew my attention to evaluate all these patients. This is a patient we've done in our charity mission. It was in Emirates. And you see here, this is the injection to the RPA, and you see here, there's a vertical vein going up. But see what happened when we cross. You see here, the sheath from the vertical vein to the LA. So there was dual drainage. Again, this is support the belief that those patients, they might have dual drainage, whether you've seen it or you are not able to see it. So after that, we took it as a routine to evaluate those patients. You see here in this patient, there is a vertical vein. This is a balloon occlusion. You see, with balloon occlusion, no more vertical vein. So it's easy to occlude. You see now here, almost if you see this as if there is no connection, but that's not true. Connection is there, whether at intrasegmental, intralubar. So I think you can safely occlude it without a problem. And In our cases, we have more than 6 years follow-up. Pulmonary artery pressure is normal. See another patient. You see this is the same patient, occluded. We make sure that they from SVC is fine or they nominate vein. We report our result. We have 6 cases. We have 2 cases, but this is few years back. Now we have almost reached up to 12 cases. This is one of the cases in Mission. You see here, clearly you can see the vertical vein. And then you see the wire. Imagine it goes way down. But nevertheless, we do the occlusion and nothing happened. You see here, this is the injection to pulmonary artery. All segment of the lung is supplied and there is no problem. This is the injection afterward. You see here? So we occlude the vertical vein with no problems. This is, as I told you, it's associated with an ASD. This is the same patient with vertical vein occlusion and ASD closure. Okay, this is a patient which is taken from my friend again with a scimitar vein on the left side to the IVC. If you see here, this is the scimitar vein, and he managed to occlude it. You see, occluded, and the pulmonary veins drain normally to the LA. This is another patient with scimitar. You can see it's draining to the. This is the scimitar vein, but he managed to occlude it, and the pulmonary veins goes to the LA. So, partial anomalous pulmonary venous connection with dual drainage incident is difficult to estimate, and it's often patients are asymptomatic. That's why we underestimate them. Okay, more common than what we expect, and partial anomalous with pulmonary venous connection is amenable for cath intervention. In my opinion, that careful assessment is needed, but the left partial anomalous pulmonary venous connection, it is almost, in my opinion, 100% has dual drainage. So I think it is safe to occlude them. And since we try to look for those patients, we occlude all of them with no problem. Okay, thank you.
The next is about S3D closure.
Sorry?
Sinus venosus
Okay.
closure.
Go for next, please. How many minutes? No, that's okay. That's up to you, but I'm happy. How many minutes?
Free.
Here. Last talk, please. Yeah. Okay. I think, again, this is almost like a part of the previous talk. In my opinion, that sinus venosus, ASD, is a misnomer. This is not an ASD. It's a connection or a window or a bridge between the pulmonary vein and the SVC. And anatomically, if you see here, this is the septum primer or the floor of the fossa ovalis, where anatomically we should call them atrial septal defect if they are within this floor of fossa ovalis. So here there is no septum. It's actually a fold between the two atria. It's a muscular ridge here. So in a partial anomalous or sinus venosus ASD, if you see here, this is the pulmonary vein. So it has a drain, one to the SVC and one to the LA. So two drainage. So our aim to occlude this. So when we occlude the drain here, that means this pulmonary vein is rerouted to the LA. Okay? So basically, it's again a dual drainage pulmonary vein. So our aim to occlude this one. And this is, if you want to read more about this, this is one of my friends in Oman, and Anderson, yes. They comment on this and they revisit the anatomy of the sinus venosus defects. Until recently, the sinus venosus defect were exclusively treated surgically. Okay, transcatheter close has emerged as an alternative option, and this procedure was first described by Dr. Hussein Abdallah and his colleague in the Frankfurt CSI meeting in 2013. There is a different operators and different technique to implant the covered stent in the superior vena cava to close the sinus venosus defect and redirect the flow of the anomalous vein back to the left atrium. Strategies have been evolved to minimize the procedural problem, which is basically embolization of the stent is one of the bottleneck of this worries in these procedures. Multiple technique has been described to improve the outcome. Pulmonary vein occlusion and stent migration are the two major problems in this procedure. The device which is yet available for this procedure is the Optimus stent, which is XXL covered stent. It's a 10 zeg, and it comes between an 80 and 100 millimeter, which is 8 to 10 cm length for this procedure. But the problem is this is not available in many places. Okay? So the first NIDAS case which is encouraged us to do more and more was a friend of mine's daughter. He is a physician, he's a pediatric cardiologist, and his daughter having sinus venosus ASD. She is a university student and she refused surgery. So we have to borrow the Optimus stent. It's 80, this is 8 cm, sorry, this is 8 millimeter. And I invite one of my best friends who is very experienced in such a procedure. His name is Dr. Yunus Boujamalain, and he helped me to do this procedure. And basically, this is the procedure. You can see a sheath from the neck and a sheath from the femoral vein. You see the catheter is through the same defect into the pulmonary vein. Here, it's under TE guidance. We introduce the stent from the neck. I will explain thoroughly about this. And then when we introduce the stent in position, you can see the stent is now freely mobile but controlled with a suture up. I will show it to you. And then we start to inflate based on this is the connection here. So we start to use a balloon from down. We inflate carefully, slowly, till we seal the defect completely. The problem is we don't have this Optimus stent, so we have to use our own, from our own cath lab. We have to use the available items to treat our patients. What we have in a catheter lab is the covered Bentley or B-graft stent, which is the maximum length is 48. These are the CB stent, covered stent. So we combine these stents together, we suture them together, and we treat our patients. So I have 3 patients. This number became now 5 patients. All of them are adult, and these are the weights. They have the CT, scan, and echoes. So this is the stent length. You can see from the bifurcation down up to here. This is the area of concern. So covered stent has to cover this area, but not cover they should not cover the azygous vein. Most of the intervention, they said if you occlude the azygous vein, no problem. But in my belief, we should not cover the azygous vein if you could save it. So we use, this is the length, this is the diameter of the balloon or the destination balloon, which is from here up to here, that should seal the defect. Okay, so based on the CT, and the measurement, we decide for the stent measurement. Okay, so this is from here down to the azygos is uncovered. From the azygos up to here is covered stent. So we do the measurement, and then this is again another illustration of the stent. This is the covered stent length. This is the balloon diameter, or here. So we choose almost like 2 to 3 millimeter bigger. Okay? So we do our stent. The total length of the stent is the covered stent from the azygos start till down up to here, and the uncovered or bare metal stent from here down to the innominate vein junction. So this is the way to do it. So we bring two stents together. This is the Bentley or B graft. We suture it with another stent here, you see. So this is covered, this is bare metal stent. You see the length here is almost like 84. 60, 70, 80, this is almost like 84, okay? So we prepare the stent. The most difficult part is the stent preparation, because suturing the stent in the right length is a time consuming, okay? We use how to suture the stent. We used to suture the stent at 3 different cells. It's interrupted way of suturing, and we use the strong silk 02. So we ensure that it will not rupture or do embolize during the procedure. This is the way to do it. When we prepare the stent length, then we put another suture loop to control the embolization. This is, if you notice here, another suture. The length is almost 1 meter, so we make a loop through this cell like this. You see here? And this is published by Dr. Boujamalain, Dr. Ziyad Hijazi, the temporary suture holding technique. This is the suture holding technique. So you see here, we flare up the stent and we put the loop here and then exteriorize outside the patient from the neck. And I will show it to you here. Okay. So basically, the operator is standing here. We have a femoral vein. We have a neck vein. This is 18 French sheath. This is 12 French sheath. We put the stiff wire from here exteriorized outside the patient up to here. So this is the stiff wire. And then we use a small balloon, for example, 1460. We introduce from here outside the patient up to here. This is the balloon now here. You see the balloon? Here. This is the peripheral balloon, 1460 or even 1260, does not matter. Anything available is good. And this is the suture loop in the edge of the stent here. You see? And then we mount the stent over the shaft. So now imagine, the balloon is coming from here up to here. Then the stent is mounted on the shaft. The balloon is here. This is the stiff wire, and this is the suture loop. In addition, the other line from here with a catheter crossing, using the same defect here, we engage pulmonary vein. So this is monitored during the procedure. So what happened now, when we mount the stent, the operator is here. So the assistant will hold the suture here and straighten up the whole assembly here, and then the operator will pull the balloon from here. So when we pull from here, the stent will come inside. It's controlled. So actually we have suture controlling the stent, and the balloon is here. So we introduce through the 18 French, and it's easily coming there. This is basically, it's under GA with a transesophageal echo. Definitely have to be careful about the hibernization as usual procedure. It's nothing fancy. And monitor during the procedure for pulmonary vein pressure. So what happened now? So this is the procedure. So pulling the balloon back, this assembly will come inside. Okay? So then when what's inside the patient, I'll show you now in the catheter lab. Okay, so now, this is the catheter. This is snared outside. So we have a stiff wire from the femoral vein to the neck outside. So now you see the stent suture and coming through the neck sheath. You see here? So now we pull the balloon from here. The balloon will come inside. You see? Now this is the sheath. So the small balloon we used to pull inside, we inflate till we have a railway for the big balloon. Now the position, this stent is moving like this, but holding with the suture, no problem. Okay? So what happened? You see here? You see now, you see the stent here is moving, no problem. We can inject, we can position, no problem, and then we introduce the big balloon from down. Now it's under control. So we remove the small balloon, we introduce the destination balloon or the biggest balloon. Okay? So what happened now? We can control by TE which place to inflate. You can slowly we inflate, we monitor the pulmonary vein, and we take it step by step. It's a very well-controlled procedure. The risk of embolization is almost close to zero. It's not a big deal. You see here? So at the end, we inflate, and this is the final. You see? This is the injection at the end. You see here? It's up to here and completely sealed by transesophageal echo. You see? These are the pulmonary vein. If you have a problem, sometimes to inflate, we might inflate the balloon in the pulmonary vein to protect obstruction. Okay? If you are worried, if you inflate more here. But it's a very well-controlled procedure. See the stent, as I told you, it was 84. See the measurement here? It's almost 84. These are the balloon diameter, 25. And here, almost like a 20. And this is the echo. See here, this is the big defect here. It's almost no shunt anymore. Okay? This is the second patient. It's almost similar. So, this is, by the way, it's bilateral SVC, so it's make it easy for us to intervene. Bilateral SVC. So, you see again, this is the injection. We introduce the stent from the neck. You see it's moving. Here, you can see it's one covered stent, overlapped with another one. And you see here, long one, and this is the bare metal stent is here. You see here, two covered, overlapped with the bare metal at the end. You see here, we inject, and this is the final stent in position with no more shunt by echo. This is the echo. You see here, no shunt. Okay? This is our final case. You see here, it's almost similar. This is the azygous vein. You see it here? This is the stent introduced from the neck, and we can move it up and down, no problem. Then we come from down, we inflate. This is the azygous vein, no obstruction. You see? And this is after the procedure. So, in conclusion, this is a modified, a novel approach for the sinus venosus defect with 100% success in our cases, and there is normal ECG and no residual shunt. It's a very well-controlled procedure. It's almost negligible stent embolization, and in relation to the azygous vein, we tend to keep it patent. And most of our cases, the azygous vein is patent, not occluded. I think this is an advantage to do this, to use these multiple stents in a place where you don't have the right items. Okay? It's like our center. Okay? So, in conclusion, thank you very much, and it's my pleasure to be here again.
Thank you very much. That was a remarkable talk Dr. Mansoor, and experience that greatly enrich our knowledge and insight. You can sit here and we will have some discussion. Is there any question or comment from the audience? Yes, Dr. Raditya first, and then.
Thank you, Dr. Mansoor, for the great lecture. So, first of all, we appreciate the King Salman team that helped us to overcome those problems. But here in Indonesia, or especially in the National Cardiac Center Harapan Kita, the problem is only also for the budgeting, since we are, but the budget comes from the universal coverage. So as we discussed, and we did quite a lot the interesting interventions like you presented, but mostly we don't have the big stand for interventions such as for coarctatio patient and also for the SVC case. So we that's the problem. Also for the peripheral balloon, yeah, the price is we cannot afford for that. I would like to comment for the interesting case for partial anomalous pulmonary vein drainage intervention. So, how to just make sure that there's another drainage to the native pulmonary vein instead of the anomalous.
I think, thank you very much again for your nice comment, but I think this is the perception for many years that a partial anomalous pulmonary venous return to the innominate vein, usually, especially on the left side, it's a single drainage. That's why people tend to say it's not fit for surgery, don't do anything, leave alone, no harm. Interesting. In few cases, you can clearly diagnose the two dual drainage that I show you. But in some of them, you don't see with your eyes or the CT scan or angio the dual drainage. But you can find another way to ensure that they have dual drainage. What? We tend to balloon left upper pulmonary vein. That means somehow the dye goes to the left upper pulmonary vein or artery, it drains to the LA, utilizing the other segment or loops of the lung. Okay? Not only this, we tend to monitor the pressure in those patients for more than 25 minutes, and there is no increase in pressure. So, if you put an occluder there and inject, you see no more dye goes up. Not only this, we brought two patients, okay, which is they have long follow-up, and we cut them again. All pulmonary veins are normal. All dye goes to the whole segment of the lung and drain normally, and the pressure is normal. So you can see it, you can cross it with wire, but not in all patients. Sometimes you see the wire goes down, and you hardly believe that there is dual drainage. But when you occlude and inject, for sure it's a dual drainage through the other part of the lung segment.
Is it the same as if the pulmonary artery segment is derived from collateral. Is this the same analogy or not? So if we conclude the collateral and the rest, the arborization must be good. Is the same analogy or not?
I think it's almost same. If you think of it, it's a competitive flow, whether through this vertical vein or within the lung. So in my belief, the flow will take the most easier route. The vertical vein is bigger, the pressure on the right side is lower, so it will go there. That's why the pulmonary vein connection to the LA is underdeveloped. So if you force them with time, you restore the connection to the LA.
Okay.
Yeah. Is there any other question? Oh, I would like to ask you, what is the limit age for this procedure of SVD closure?
I think it's a good question, but I think the problem in this intervention, I think it's like any other intervention, is the weight and how much do you expect this patient will have a future re-intervention. In adult, probably they may not need more than maybe one procedure, and that's it, because you don't need to dilate the stent more than 25 millimeter per. In pediatric, we may do it, I think technically, if the patient is more than 30 kilogram or maybe 28, we can do it. But do we need to do further intervention when they grow up and in future? Maybe. But the limiting factor, in my opinion, is the weight and the rate of intervention that you expect with time. So I guess anything above 30 or around 28, 30, we can do it. And a friend of mine, Dr. Ali Jelly, I knew he did the sinus stenosis for a 7 years or a 7 years old girl. She's doing very well. But in future, what will happen? Not working? Yeah. So what will happen in future? I don't know the answer.
Is there any question from the Zoom? And how about if there is an obstruction of the right pulmonary vein? Is that also suitable for this procedure? Obstruction of the right pulmonary vein, for instance?
You mean the sinus stenosis?
Yes.
Okay. Yes. The concern is the pulmonary vein obstruction. That's why we do a meticulous monitoring of the pressure into the right pulmonary vein during the procedure. And if it happens, it is no harm by putting a balloon and dilate the stent, because I think the mechanism of closure is overinflation of the stent will push the pulmonary vein posteriorly. So if you inflate balloon within the pulmonary vein during the time of the inflation of the stent in the SVC or the lower end of the SVC, I think you will prevent the obstruction. So I don't think it's a major problem. Even if it's happened, we can dilate and there is no problem.
From the Zoom, there is a question. Yes, you can.
Okay. As we broadcast this lecture to Zoom, there is a few questions. The first question is from Dr. Andi Alif from Makassar, and the question is: what is your opinion about using covered stent in children age for coact and PAPVD case? Is it possible to resize when the kids grow up? Thank you.
Can you repeat the question?
Cover stent.
Can we use the cover stand and
What
then
case?
we can, when the child will grow up, can we redirect again?
Yeah. Yeah, so let me repeat the question. He's asking about the covered stent in pediatric age group. Am I right? Yes. Yeah. I think it can be used, but I will tell you my own personal experience. I tend to not put a covered stent into pediatric age group. Why? because the covered stent, the profile take a bigger sheath. And in pediatric age group, we tend to save the vascular access in the children. Most of the patient, I would say more than 80% of the patient or coarctation in the pediatric age group, we can go away with a bare metal stent. But yes, the answer is yes, we can use a covered stent and we can dilate, and we have seen no problem with that. But this again, my concern is to minimize the vascular trauma for the artery in children.
Is there any other question?
Yes, there is indeed a question from Dr. Yofi Kurniawati. The question is, in what kind of cases that you usually look for or ensure that there is no dual drainage of PV? Is it cases that you find accidentally from CT scan? Thank you.
Yeah. So the question is about the dual drainage on the partial anomalous pulmonary vein. Yes, actually, as I told you, the story started after our case, which is had surgery, and then we realized the native pulmonary veins restored at the age of 10 years. So when we looked carefully, sometimes we can see the connection of dual drainage, but in majority, now I told you 12 cases that dual drainage only I was able to cross in 2 patients, dual drainage, but the rest, you don't see them. But when we occlude the vertical vein, the blood goes to the whole lung and go back to the left atrium in the same manner, no delay in the upper loop or middle loop or the other. So yes, you can see, but not all of them. And nowadays, we don't do a major evaluation for the to cross. Only we occlude, inject, test. If it's okay, we occlude the vertical vein. And yet, there is no single patient with partial anomalous pulmonary venous connection on the left side that was not able to be occluded and treated in the catheter lab in my patients.
Okay. I have a question about one of your case. You present a residual AP window and you close it. Is it possible to close the AP window in the first stage?
Yeah, that's a very good question. I think yes, it's possible. If you think of it, it's possible. But most of the window that you saw, they are a huge huge connection between the ascending and the PAs, and it's close to the semilunar vein. So I think the limiting factor is the proximity to the nearby vital structure. But theoretically, it is possible. If you think of it, if you are able to occlude the defect without compromising the nearby structure, it's possible. But as I told you, my surgeon, they do ligation of the window. So it's an off-pump case. So that's why they have residual. And I have 3 cases. They tend to have a shunt afterward. And we brought the patient to the cath lab and we closed them. And it worked very, very well.
Yeah, Dr. Mansur, this is already answered. I think this is already answered, yeah? Is there any others? Yes, one more from Dr. Bagus Artiko in Solo, Mid Java.
Yeah. Yeah. So Dr. Bogas Artico, he's asked about the future plan for this patient. I don't know. I don't know. But what I know currently that we saw this patient since 2018. He had the first intervention. He was severely depressed function. He was not able to be discharged from hospital. We intervened. And then he came another 1 year with aneurysm below the stent. We put another covered the stent. Luckily enough, now the function is normal. The boy back to the activity with no issue of paralysis, alhamdulillah. So he did very well. Since now it's almost 7 years follow-up I have. He's doing very, very well. We will plan to see him in a few months in Yemen. So hopefully we can see him, we can evaluate him. But yet he's doing very well. The long-term plan, I do believe this patient has a major problem with his large vessel arteries. And you can see it, most of the vessel is abnormal and stenotic and tortuous. So this is the nature of the disease. I don't know the answer. But the current intervention helped this patient for the last 8 or 9 years. This is what I can say.
Yes. You want to ask question? Yes,
Yeah.
please.
Yes, dokter. Assalamualaikum warahmatullahi wabarakatuh. My name is Rama, a cardiology resident. I want to ask about the regarding one of your procedure about SVD closure using covered stent, sinus venosus defect management using covered stent. I want to ask regarding the safety of the procedure. As we know that near the sinus venosus there are SI node and also pulmonary vein. And how is the risk of pulmonary vein obstruction after implantation of covered stent, and how is the risk of the SA node dysfunction after the implantation of the covered stent, and how you manage the risk and mitigate the risk before? Yeah, thank you.
Yeah, thank you very much, doctor. I think you alluded on the two possible risks in this patient. So let me start with SA node function. SA node function is definitely a problem in the surgical approach. Whether it's a Warden procedure or the double batch technique, they have a problem with SA node dysfunction in future, for sure. It's a surgical issue. From the literature, I can tell you that there is a paper reporting on sinus node dysfunction even after the stent. But those patients, one of them, he had a sinus node dysfunction, and he required a pacemaker in future. That's why people now tend to do balloon occlusion inside the cath lab to inflate to see what will happen to the sinus node at that time. So if the patient develops sinus node dysfunction with the balloon occlusion, they will consider him not fit for intervention. But if you read the literature and review the literature across the globe, which is not many cases, I would say less than maybe 150 or so, few patients, 2 or 3, develop sinus node dysfunction. Only one had a pacemaker, okay, after the stent. So it is possible, but if you think of it, the sinus node is in the epicardium and the stent from inside. So probably the chance to have a sinus node dysfunction will be lower in catheter approach rather than surgery.
Yeah. Interesting.
Pulmonary vein, sorry. The pulmonary vein is, sorry for interruption. We just discussed a while ago, but the pulmonary vein is monitored all through the procedure. If any compression, we can dilate the pulmonary vein and dilate the stent at the same time. So we keep patency of both lumen at the same time. I don't think it's a problem, pulmonary vein. But it's a major problem in the surgical approach. If you do a Warden procedure, all of them, they will develop SVC, not all of them, but majority of them will develop SVC obstruction and pulmonary vein obstruction.
Yeah, this procedure has been introduced by a pediatric cardiologist in Baghdad, I think.
Hussein Abdullah Hussein, yes.
Sir Dr. Abdullah, in 2013.
13, yes.
But afterwards, there is not so many experts doing this procedure. There is recently a report in a journal written by some pediatric cardiologists in Nantes, Paris, Nantes, France, which is reporting about more than 100 cases in this 2024, I think. So why this procedure is not so popular?
Yeah, I think the answer.
Is that any difficult?
No, I'll tell you. I think the difficulty in this procedure is we don't have the right device for such a procedure. And this device is not FDA approved. And there is no CE mark approved yet for this device. This is the difficulty. But I can tell you the trend for catheter closure of the sinus venosus defect is getting more popularity, and I think you will see more intervention in future rather than surgery.
Yes, you have so many experience. Dr. Mansour has finished his medical education and pediatric training in Saudi Arabia, and in 2002, 2004, for 2 years, he was trained in Royal Children's Hospital in Melbourne, where I and Dr. Poppy and Dr. Indri Wanto was trained. So we know our colleagues, supervisor, Dr. James Wilkinson, Dr. T.H. Go, and we are same alumni.
Well, it's my pleasure today that I met one of my colleagues now, my senior colleague there.
Yes,
Yeah?
but I was there, and Dr. Poppy also 15 years prior to your
Not
training.
that very long time.
Yes. Is there any other question? Maybe Professor Ganesha or Dr. Poppy or Dr. Indriwanto has some question? Yes, please.
Thank you. Professor, I'm sure we enjoy your talk very much. Just curious, nowadays, transcatheter closure of ESD, VSD, PDA is booming around the world. And just curious whether before you close the VSD or ESD, do you always measure the flow ratio?
It's a very good question, but I can tell you that across the globe, most people depend on the clinical background of the patient as well as the echo finding. If you find this patient is by echo is hemodynamically significant, personally, if you ask me personally, we are not doing shunt calculation anymore. I think it's useless. Why? Because in the shunt calculation in the catheter lab, it depends on many assumptions. It's a time consuming and should not alter the decision. I know that people might stand up from the room and said, no, it has to be more than 1.6. Yes, fine. But in my belief, if the patient by echo has signs of volume overload, there is a significant shunt. Plus, the problem, not only the shunt sometimes, is shunt and the risk of future problem, which is cumulative, which is the infective endocarditis. I knew that infective endocarditis is a problem in certain countries like our countries or developing countries is a problem. Not only this, the procedure now gained popularity and the risk of complication is much less, and the device has been improved, the equipment improved, and people now gain a lot of experience when to close or not to close, and what's the risk of heart block is always there. But we learn a lot about this issue. So the answer is no, I'm not doing a shunt calculation anymore.
So, conclusion is you close all VSD, all ESD, regardless of their flow ratio.
No. So, let me throw the question back to you. Sometimes we can find a large ASD secundum and you do calculation and the shunt is 1.5, which doesn't make sense. Those patients tend to have a problem in future when they get adult, okay? So, in my opinion, that we close the defect when there is a signs of volume overload. This is parameter before we
That's
start.
it.
Yes.
That's the point.
By echo, yes.
Yeah.
There has
Yeah.
to be. Suppose there is small PFO or ASD with no signs of volume overload on the right side. No, I will not close.
Okay.
Yeah.
Thank you.
Yes, I think we have 35 minutes more. I would like to give the opportunity to Dr. Raditoyo Prakoso, our senior pediatric cardiologist interventionist, to present his experience, the experience of our center.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Praise to our Prophet Muhammad sallallahu alaihi wasallam. First of all, I would like to welcome the King Salman Relief instead of our senior Professor Ganesha, Dr. Anna, Dr. Poppy, Dr. Indriwanto, and also the fellows and all residents. Today, I would like to share about our recent intervention. Is from simple closure to advanced stenting, a landmark over the year experience of congenital heart and structural heart disease intervention in Harapan. Next slides. Slides. So, since the introduction of the percutaneous procedures, everything is changed. Classically, congenital heart disease mostly are closed by the surgery. And why we are changing that? Because without prolonged ventilator support, faster recovery, and more feasible to do across Indonesia, since we only have little center for the advanced surgery. Slides. First, I would like to introduce our innovation about the septal defect closure. Is first still with fluoroscopy, but we do not use any contrast. And the second one is zero fluoroscopy approach, so totally do by echo guidance. Slides. Slides. So, traditionally, percutaneous device closure is done with help of fluoroscopy plus echo. And you know, what is the concern? Because the cath lab personnel were repeatedly exposed to the ionizing radiation. Yes, last 2 days, Dr. Mansour shared to me about the college from Kazakhstan, and they said the cath lab personnel do not use apron. And what did they say? We are survived. We have survived from Chernobyl, so there's a little radiation. So you can see, for the doctor, I don't feel anything but cataract, cancer. So chronic exposure will deteriorate all the team, not the patient. The patient only once, but the team every day. It's terrible. Slides. So first introduced by Dr. Peter Ewart, and then Dr. Pan Xiangbing, and then in Indonesia, this is our team. Slides. So this is our case for zero fluoroscopy. 4 months before I met Dr. Pan Xiangbing, he visited Indonesia and introduced to us about the zero fluoroscopy technique. And you know, all of the audience says, why we are using for the zero fluoroscopy, since we have the better methods. 4 months later, the patient come, graphic woman with a severe heart failure. I give the conventional treatment, frostbite, etc., etc. And the OBGYN called me and at the time said, Radityo, the patient suffered of oligohydramnion. So you have to stop the diuretics. And I see the patient is still in a functional class 4, New York Heart Association heart failure. So at the time I have to close the defect. So I sent her to our cath lab, and at the time, after the whole preparation, and Marshall or our echo colleague said, shall we do it the zero fluoroscopy technique? And I asked her, is it possible? Yeah, it will be impossible if we don't try. By the grace of Allah, alhamdulillah, in 40 minutes we can close the ASD. So, if you are interested, you can read our paper slides. So, afterwards, we always attempt the no radiation intervention with zero fluoroscopy. But we realized that not all the candidates or not all the patients can do with the zero fluoroscopy slides. So sometimes it's difficult to overcome the tip of the wire, or tip of the catheter. It's quite difficult, especially for the adult patient with the emphysematous problems. Also, that's a blank area. So, another challenge, operator dependent, limited visual field, as I told you, and difficult to visualize. And we changed to zero contrast. We still use the fluoroscopy to see the tip of the wire, but we don't need the contrast. Why is that? Because we can see from the echo. Slides. So this is our zero fluoroscopy milestone since 2018 until now. It's nearly 500, more than 500 intervention done by zero fluoroscopy technique, and we have published it. Slides. And it's more and more also published. Slides. Okay, even in the complex case. This patient, because of oval-shaped ASD, we need the balloon-assisted technique. So we use the zero fluoroscopy technique for putting the device. And first we deploy the balloon there. And what's the purpose of the balloon-assisted? To make sure that the left atrial disc goes to the left atrial and the right atrial disc goes to the right atrial. After the position is good, we deploy the balloon, and you can see the devices sit nicely. Slides. So this is also for the small babies approach. It's currently is quite difficult to cross and put the anchoring wire into the pulmonary vein. Why is that? Because sometimes we do not have the TE probe for small babies. So we use for the SVC approach. Once we approach the ASD, we just counterclockwise the sheath, and then it goes to the right atrium. Slides. So complex ASD with the minimal posterior rim, and we use the balloon assisted to put the device. Slides. This is the simultaneous ASD and VSD closure in small neonates, small babies. Sorry, we use the retrograde transvenous approach to cross with no snaring technique, and we can see that since the VSD is perimembranous, so we can easily go from the right side. And you can see here, there's it looks like the disturbance for the tricuspid, but it's due to the cable. And you can see the residua comes from the device. And you can see also for the aortic involvement, there's no AR. So the patient was followed up for 3 years. Till now, the patient is in a good condition. Slides. This is the follow-up. It's good. There's no regurgitations on the valve. Slides. Spiral type ASD. This is my first spiral type ASD with the height defect. Height or deviation is almost 8 millimeters. So we used to oversize the defect, and still with the zero fluoroscopy way. Slides. And then we do the left pulmonary vein approach. We use the balloon, and then we put the device. You can see the device malalignment. But for the follow-up, we did it at the last June, and then until now, the there's a clinical improvement, and then there's no sign of the pericardial effusion and also the erosion. Slides. This off-axis doubly committed subarterial VSD. You can see, first we cross it with the fluoroscopy. It's very easy with the right RAO approach, and then we deploy the device under TE guidance. You can see it's only slight pulmonary regurgitation. Slides. Here's the transjugular access for the muscular type VSD. You can see easily when we put the catheter from the jugular vein and then goes to the right atrium and right ventricle and easily cross, and then we change to the sheath and we put the ASD device there, and then the results good. Slides. So this is the welcoming era of the stenting in congenital heart disease. Slides. So previous indication RVOT stent in the world, mostly RVOT stenting is done in the young children or neonates to promote the growth of the pulmonary artery to replace the BT shunt at the time. But what happened here, slides? This is our story, that we put the RVOT stent not at the neonates, but on the late placenta. So what happened there? The RVOT stenting will improve the saturation and ejection fraction. So the issue, not only the saturation, but the issue also regarding the ejection fraction is due to the chronic hypoxemia. So another point is in adults congenital heart disease, so we put the double stent due to the high distortive force. Slides. So it's also inspiring other countries that face similar issues. Slides. So what is RVOT stenting? So follow, it should be total repair. But eventually 25% of the follow patient cannot go to the total repair. Why? Because first, there's no adequate pulmonary artery size, mostly in children. The pulmonary artery size is diminutive. The second one, the ventricular function. More an adult patient we face on the deterioration on the ejection fraction. And it should be total repair in less 12 months, is according to the guidelines, but cannot do here, you know. And based on the paper published by Professor Indah, it said that more than 50% congenital heart disease come in Indonesia in the late presenter. And 80% of the cyanotic heart disease is coming late. And so it needs the palliative procedures, the surgical procedures classically, or non-surgical intervention. Surgical procedure, they are not accepting if the major comorbid, such as severe infection or decrease of the ventricular function. Slides. So this is the LV systolic function in cyanotic heart disease is a preoperative threat. Many problems, but the problem mainly is because of the chronic hypoxemia. And you can see it's the BT shunts versus RVOT stenting. Actually, from the literature said, the RVOT stenting had a better option. Slides. And this is our first case. This worker on the kelapa sawit fields in the North Sumatra is coming with the heart failure. Currently, actually, he's patient of the internal medicine department from the hematology division with the problem of polycythemia vera. Couple of bone marrow puncture showed normal morphology, and they are referred to the cardiology division, and they found the large VSD with the low ejection fraction. So they sent to Harapan Kita, and our assessment showed the tetralocular follow with a low ejection fraction with very tight pass. And you know the peripheral saturation is only 40%, and at the time the patient was hospitalized in the intermediate ward with a heart failure functional class 4 and also hypoxic pre-spell. So when we put the water, the patient got the heart failure. When we give the furosemide, the saturation decreased. So I was asked by the deputy of the director at that time, what's your plan in this patient? Because the bill is getting higher. So I sent him to the cath lab. This is my first case. And what happened? The stent is dislodged. Why? Because I stent the right ventricle. Bad idea, but I have another plan. I put another stent of the RVOT, the saturation increased, and I call the surgeon. And I snap the stent, I put the right atrium, the surgeon got the stenotomy and stitch have a cut down on the right atrial appendage and evacuate the stent. Patient is already total repair now and is in good condition. Is functional class 2 with he can do again his work in the Kelapa Sawit field. Slides. And this is our paper about the adults with the RVOT stenting. The mainstay is RVOT stenting is safe for adult population and will improve the both saturation and ejection fraction. Slides. And this is the first case, you know. First, what you know, where's the stenting? This in the RV. I have to put more advanced. And the next, I put longer stent, and it works, and I snare the stent. Okay, slides. Another case, what's the challenge to put the adults with RVOT stenting is to cross the RVOT. The RVOT tends to be very, very tight. So it's quite difficult to there. We have to modify it, how to do first. We have to pre-dilate to prevent the cyanotic spell in the cath lab. Once we cross it, we put the vascular balloon slides and also the double coronary slide, but double vascular stents. Slides. Hang, yeah. Slides, yeah. Okay, you can see the follow-up. The ejection fraction much better. Slides. Okay. And this is the follow-up. The pulmonary artery size also improving, and we can do the plan for the total repair. Slides. Yeah. And this is the 3 months follow-up. The ejection fraction getting better. Slides. And this is after the total repair. Patient in a good condition. Slides. This is our first PDA stenting in Harapan Kita, 2013. So at the time, the prostaglandin infusion ample is off. There is no prostaglandin infusion at the time, and I'm on duty at the time, and I said the saturation is only 40%. This all at the time, the basic pathology is pulmonary atresia with duct septum. So at that time, I should do the pulmonary valvulotomy. And after, but in the midnight, we cannot do at that time. Yeah, so I put the stand. At the time, we put the bare metal stand. And after that, we do the radio frequency. In 2018, I have one machine from Osipka, but now it's gone. We do the radio frequency valvulotomy, and then we do the balloon pulmonary valvuloplasty. After that, the patient in a good condition, but there's a disturbance in school. The mother said it's a difficulty to study at the school. So because of the low concentration, and the saturation is around 88 to 90%. So I put the PFO closure, and after that the educational mark is increased. The patient in good condition now is the patient in junior high school. Alhamdulillah. Slides. This patient for the thing. Can you play the film, please? Before this, we usually use the transfemoral approach for any PDA standing. But after we realize that the vertical PDA can be easily done with the cut down from carotid, so we put the stand on the from the transcarotid. And if you ask why don't we use the right axillary approach, because we have experience to have we cannot stop the bleeding from the axillary artery, so it's easily to go as the surgeon goes to make a stitch here and then repair it. After that, we have a good pulmonary artery size, and the patient slides, please. It's due to Glenn shunt. The patient in good condition. Slides. So the pioneering, the new idea is not always easy. You can see stand cramping. So maybe a couple of months after the first adult with the RVOD stenting methods, the stent is cramping. So this is the first case at the time. I'm flying away from Jakarta, and after Fajr praying, the doctor in charge called me that the patient got spell, hypoxic spell again. And you can see from the rotational fluoroscopy, you can see the stent cramping, and from the TE you can see it's very cramped. So I put another stent. It's good. Since then I put the 2 stent, and till now alhamdulillah it's fine. Slides. Okay, slides. So we try to innovate by using the carotid artery access. Yeah, I have told you before. Slides. Before that. Sebelumnya. So procedural complication were higher in femoral access than the carotid access. The incidence of acute limb ischemic also higher in the femoral access. And no acute thrombosis occlusion in the carotid artery was assessed by carotid vascular ultrasound in 2-day series. Slides. This is the pulmonary valvulotomy. I think, it's not interesting. Slides. So before that, now, I think we have discussed with Dr. Mansour with antegrade versus retrograde approach for the pulmonary valvulotomy, and I've published it. And in certain anatomy, we can use the easiest way with good results. Slides. Intra-arterial stenting for the primary pulmonary hypertension. If you ask me why we don't use the arterial flow regulator, because it's very expensive. So we put the vascular stent, and it improves the functional class of the patient. Slides. Yeah, slides. So what next? How far the work progress of treating congenital heart disease? Slides. I think This our challenge. Maybe King Salman Relief Team has done some of them slides. So historically, Indonesia fall behind in congenital heart intervention due to limited resources, infrastructure, and expertise. In the recent year, progress surged through better policies, technical investment, and more specialized center. However, challenge persists: unequal access and need for continuous professional development. Our journey offers lessons to other developing nations, improving their healthcare system. Next, thank you very much.
Thank you very
Assalamualaikum
much,
warahmatullahi
Dr. Radityo. We are very proud to have you in our center, as good as Dr. Mansour in Saudi Arabia. So, maybe there is some question or comment. Yes, Dr. Mansour have a comment.
Can I comment? Oh.
Our guest first.
No. Enjoy your talk, Dr. Radit. On your last slide, you mentioned about our limited resources. We now have BPJS. Why is still limited resources?
Because the device is limited, Prof. We cannot use some device. So still limited. Thank you.
Yeah, I really enjoyed the talk. It was very, very good talk. And I like the way your people are thinking. I think it's a great idea as always. I learned most of the things that you mentioned in a hard way, honestly. I told you the story of the lady who said, who cares about radiation? This is a true story. And her answer was very simple. We survived Chernobyl crisis. Do you think it's matter? She's very ignorant about it. I'm not fighting for this. I mean, voting for this. Definitely not. But we learn in a different way. I remember one story to share with you that we were in Sudan, and the electricity in a cath lab shut down 16 times during our mission in the cath lab. And one day, we were doing an AST. The moment we start to push the sheath, there is no more electricity. And they have only transthoracic echo. So I asked myself, can I do it on transthoracic echo without fluoro? I said, let us see. Let us see. We were able to push the sheath. The sheath was just introduced, so I have to push the sheath across the septum. We put the device. There is no electricity. My intention, not zero fluoroscopy, honestly, but I have to face the fact. So we did the complete closure on echo transthoracic, not even TE. I think you are right. I think sometimes we interventionists or people, we tend to believe our perception. Perception sometimes be wrong or right. But we can do things sometimes for the patient good, for the institution and benefit, for many, many things. We can do things if we think about it. And sometimes the difficulty comes in our brain. So thank you very much for bringing this, which is zero fluoroscopy, zero contrast. Zero contrast is a very important concept in certain patients. And I remember many, many stories, which is we cannot give contrast. Otherwise, patient will be at risk of losing his kidneys. And we've done it in many patients, especially adult. It's a very big matter in adult. So again, we can use fluoroscopy, but not contrast. So I like the idea. I think it's a very important. I think physician or interventionist should think about it, and people who are the privilege to do fluoroscopy or anything, they have access to do it. They have to think one day they might face it without fluoroscopy, or patient who cannot take single contrast. Thank you. It was a great lecture.
Thank you for your comment. So, the broad experience of the interventionists make many things possible. My question is it possible to do ASD closure, simple case, just in ICU, which is close to the operating room, and not using a cath lab?
It's possible. It's possible. But I think first we have to do the screening of the patient. Is the patient a simple patient or a complex patient? And why, if you ask me, why, Radityo, you still push the patient into the cath lab? Because my equipment's there. So basically can be done, minimal in the recovery room, doctor.
Yeah. I think the answer is yes. But the context of this intervention, you have to discuss it in the whole aspect. I mean, I think if you ask me, can it be done? Yes. Why? Because we're doing septostomy bedside.
Also to our patients who come from various regions of Indonesia. We deeply appreciate the generosity of the King Salman Humanitarian Aid and Relief Center, and sincerely we hope for the continued support in the future. And we also pray that King Salman is granted a long life and good health. Once again, thank you very much to the team and also to the audience that participate in this session. I think I have to conclude this session. Thank you very much once again. Wassalamualaikum warahmatullahi wabarakatuh. You want to give a talk? You want to say something?
No. Just to tell you about the King Salman. King Salman is supportive for all the charity work across the globe. But let me tell you something. The mission that done in the last few months, actually it's encouraged King Salman to come again and again in this place. This place is a welcoming place. It's a very nice place with a very good infrastructure, and I don't think that that there is no reason for King Salman or the group, the charity group, whether surgical or medical or adult or pediatric, not to come here. I think this place, one of the most interesting, welcoming and charmful place is this place. So thank you very much for keeping this good environment with the team. We really appreciate that.
Thank you. And I hope your center in Saudi Arabia can also accept our fellow to finish or to be trained in your center. Hopefully.